Hello, and thank you so much for joining us today for the webinar Implementation of 3D-Bonebuilder in Augmentative Pre-Implantological and Oro-Facial Procedures. It is a great pleasure to introduce to you Dr. Manfred Nilius, who will discuss the possibilities and different methods of augmentation, decision-making of indications, and safe use of customized allogenic block transplants. We'd like to thank Dr. Nilius for being with us today and thank botiss for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Nilius at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Manfred Nilius.
Yeah, hello everybody from the sunny Germany. I would like to give you some more information about implementation of 3D-Bonebuilder in augmentative, pre-implantological and oro-facial procedures. First of all, I would like to talk a little bit about the techniques as a kind of overview about augmentation. The second is how to indicate different techniques. I would like to talk a little bit about the materials, and last but not least, timing of implantation after augmentation. First of all, we have different techniques. We have absolute augmentation, so-called bone splitting when it is very small, one extensioplasty or onlayplasty. You can do extensioplasty only one way in lateral, and onlayplasty in lateral, horizontal, and vertical dimension. A special kind of augmentation technique is called distraction. And last but not least, one is interpositional osteoplasty. It is a little similar to distraction, and you can do all these in the three dimension. Relative augmentation is also possible. Normally we use it when we do lift for one osteotomy for a maxillary advancement operation, or sometimes a little bit of nerve lateralization in the mandible. Also, relative augmentation is called sinus lifting, and to prevent the socket of the alveolus, the socket preservation is also called a relative augmentation. Indication. We have information about the vertical height. When the vertical height is more than 10 millimeters and the alveolar ridge is less than 3 millimeter, we need block augmentation. Otherwise, it's possible to do it with extensioplasty. When you only have a vertical height lower than 10 millimeters, you can use a very, very short implant. I will show you one case at the end of my presentation, when the ridge is more or less more than 7 millimeters. Otherwise, it is you have to do interpositional osteoplasty, or if it is limited, less than 6 millimeters needed for distraction. Otherwise, it's possible to go to the mandible and have a nerve lateralization or do a sinus lifting, and that all is depending on the intermaxillary distance. There are a lot of information in the literature about the materials. To sum it up, we can do it autolog from the patient, or we have it allogene. There are different possibilities to mix it with gelodine, bovine, equine, and porcine materials, or phycogens from the algs, and often used in Germany beta-tricalcium phosphate or hydroxyl apatite or different other things, and membranes made of Teflon or polytetrafluoroethylene. It's only a small review of the literature I can give you later on. Almost 10 pages where you can sum up all the information depending on materials or on techniques. This is only a small review, and mostly summed up for the last 3-4 years. The older ones are already known by you because you're experienced. The time of augmentation is, you do it with implantation. It's as a one-step operation, often used when you only have a small vertical deficit. You can do it in 2 steps. Normally, when you do so, there is an estimated time of remodeling of the bones after 6 months. We recommend this to wait this 6 months. Or you have more complicated ways, then you make a distraction or a 2-step automatic surgery. I will give you information in one case. This is called delayed implantology after distraction or after bone augmentation. We have some experiences with 3D-Bonebuilder techniques since 7 years, and the summary of the used botiss 3D-Bonebuilder is the last 2 years. We use from May 13 to May 15 now this year a total of 15 3D-Bonebuilder, where the success and failure rate 12:3. We used block grafts and 2 cases of max graft cortical. I will show you this case later on. And we often use in combination to the 3D-Bonebuilder or to the block allografts human spongy bone. The 3D-Bonebuilder was often used to reconstruct the aesthetic front line in the anterior maxilla. We made 5 times a posterior maxilla because the intermaxillary distance was too big to insert a good implant or a good crown on a good implant. And we had 5 cases in the posterior mandible. The success and failure rates we will discuss later on. And before we did it with block allografts, often patients say maybe it's too expensive to have 3D-Bonebuilder. On the other hand, it's more, you spend more time when you remodel the allogen outside the patient's mouth to fit it very well to the donor side. Maxillocortical and human spongy bone is also seen there. After all, and reopening after 6 months, we had a evaluation made by cone beam technology and verified by clinical findings up to 10 to 20%. Till now, we do not have any information about how this bone loss will go on after loading the implants. We are just figuring out if it's stable after implantation, or is there still a bone loss after prosthetic loading of the bridges or the implants. I will show you the very first case report we made. This was a young patient. With this clinical findings, he was forwarded to our clinic for big cysts in the lower mandible, and there was also a cyst in the upper part, which you can see on the left lateral canine. And we extracted the tooth, made an osteoplasty, and this is the first view you can have. This is normally the big cyst here and the big cyst here, but the cyst continues growing up to this side, so we needed a very big 3D block graft. And when you do so in patients, there are not so much information about how to handle kids. Normally, autolog you cannot use very good because the hip graft it's cartilage, is not a very bone, it's not a very good conditioned bone, and tibia is very bad because it's growing, so we decided to have an allogene made in different sizes. Our treatment plan for this patient at the age of 14 was to have an extraction on 6-3 and the cystectomy on 2-3 bracketing and autogenetic treatment on the left upper canine. In the mandible, we had to extract all the teeth. We made a big cystectomy and an immediate reconstruction using a customized allograft 3D CAD/CAM block. Meanwhile, the treatment was going on. We pushed him into orthodontic treatment and conservative treatment. Later on, we made implantation and prosthodontic rehabilitation. This is a case before operation, and in the lower part you can see the reconstructed bone. And this was a very big size. It was almost 5 centimeters. It was special made customized for this patient. Now, in 3D-Bonebuilder technology, it's not that big that you can put it into one block. You have to make 3 blocks or 4 blocks that fits very well into each other. But this was a very big block. Normally, we have maximum size of 6 centimeters of 60 millimeters when we do a free bone transplant. Otherwise, the literature says the blood supply is very bad, so maybe you have sequesterotomy. So, treatment plan already done. After doing this, we recognized a non-growing of that bone at the age of 16. So later on, we made a distraction osteogenesis to make sure that the prosthetic height of the bone level is very good at that stage. And you can see the orthodontic treatment as well. And the lateral upper canine is in a very good condition. When putting some implants in children, this is a big question. Normally, we wait of the dental and skeletal growth, except of severe cases of ectodermal dysplasia. So we have the case is an ectodermal dysplasia, so we decided to make an X-ray of the hand, and we find out that he was not growing on, and then we decided to make a biopsy of the remodeled bone and made some histomorphological investigation. And we found that there is still, after 2 years, adultal matrix of the allogeneic bone, and we have a cell apposition, a vital cell apposition from the patient. And this is correlating to the information we got from the literature. Then the implantation. In this case, we made a 3D planning tool with Novel Guide software, and this is at the age of 17 prosthetic loading. And still, after doing big bone augmentation and dissection osteogenesis, there is a 50-50 distance from the crown to the implants. Okay, this was made 7 years before, and here you can see after prosthetic loading, and now at the age of 21, follow-up after 4 years with a very stable bone area, and the crested bone is still growing out. So this is first case we made, and the small resume we made at that time was dental implantology and distraction osteogenesis is possible in children, even if it is an allogene 3D block. But you have to wait after ossification of RU and MP3U grade. We can use 3D customized implants for reconstruction even in children, and when you do so, you need colleagues from the orthodontic department and from the kids department, and in this special case of the Gall syndrome, you also need support from the ophthalmologists and from the dermatologists. The second case is a typical case. This is a young lady. She came to us. She wanted to have a recovery of the frontal teeth, and what you often see, you have a bite that is crown to crown. So there is a maxillary deficit. This is the reason why we decided to put in the lower jaw to recline a little bit the labial parts of the central incisors and the mandible. And before you make bone augmentation, there is a possibility to augment as well the soft tissue. This is the clinical finding or radiological finding, and this is an hydrogel self-inflating tissue expander. This is a small ball inside, and via osmotic reactions you can put in this soft tissue expander, and there are different sizes depending on the graft you put on, or depending on the size. Normally in this size you wait 18 days, and then you can do the augmentation of 3D-Bonebuilder. And this was a planning. It's a little bit, I say to my patient, look, this is not a veneer for the crown, this is a veneer for the bone. It sounds better, a little bit better when you say it's a bony veneer and not it's a big bone augmentation. And this was made of one piece, one of our first cases we made, and this is the extra-oral view, and this is the clinical situation after 6 months before opening. And on the right side you can see that there is a vertical loss of almost 10 to 20%. The first spread of our osteosynthesis screws. Normally we insert as well the head of the screw, so then we can measure how the distance is reduced. But this is normal. Normally the buccal side is the bony reconstructed buccal side, even the lateral and the mandible part is resorbed very fast. and the rest is still stable. This is the situation DVT made immediately after the augmentation of the bones, and now we have almost 2 millimeters, so it's possible via DVT to decide how many percentage of loss you have in the bone. Then implantation, and as you've seen here, there's a recession plasty made by a coronal rotation flap and used by a palatal soft tissue graft. We are still going over this case because we have to weight the soft tissue. And the second case is a genital non-dentition. Looked like this. This young lady had orthodontic treatment beforehand, but was not very. Maybe the colleague was not very familiar because the teeth were, or the apical part of the teeth were very connected to each other, so we were not able to insert implants. And the wish of this patient was, and she declared it directly to me, she wanted to have implantology and she didn't want to have any how do you say, treated lateral or central incisors. So our plan was orthodontic treatment beforehand. The patient was avoiding bridges, and after this, having an implantological approach. We start with a video sequence here. So when you decide to make osteoplasty using 3D, it's mostly not the matter of putting on the implant, it's a matter of how to cover the big augmentation. And we highly recommend having a full thickness flap, because you use the palatal part of the soft tissue to cover as well the augmentation. So, and when you do so, normally we say we need a cut of the buccal side of the soft tissue to expand it, and later on it is possible to use mucograft. Mucograft is a very, very big membrane, and this membrane we use after having the bone augmentation. It's sucked by water. Normally that is 1 hour left, but it is in a very good condition. So because the gap was very, very small, we decided to make a bicortical or monocortical bone augmentation, used the monocortical max graft, and you decided this is a diamond instrument. Maybe you're doing the same in your offices or in your departments, and this need to be screwed definitely, and you have to fit it. And you can see that the teeth, that the direction, the angulation of the teeth are not very good for implantation because you have limited space. And then you fix it. Here we had the cortical bone and was screwed to the palatal part of the recipient side. It is possible to do so, and this is molding a little bit the bone. It's fixed by a 1.2 millimeter screw, and the gap is filling. Yes, you have to fix it because otherwise the bone is not creeping. And this is human spongy bone. You can buy it as well. Normally it's a package when you have max graft cortical. You can buy it from botiss and you fill it up. Sometimes we mix it with PRGF, but in this special case we made venous blood. You have here to fix it very well, and one screw again, and filling up all the gaps, especially to the vertical loss of the teeth, splitting of the mucosa, and now you have the sucked mucograft. This is a very thick one, and this is good because sometimes parts of the grafted bone is exposed to the mouse, and this is very bad. So we recommend, one recommendation is using a mucograft, and the mucograft is minimum stable for 3 to 4 weeks, and we super exposed Emdogain as a liquid for healing to the teeth and putting on the mucograft, covering the soft tissue defect, and later on make some stitches. And then you can see that the palatal part of the soft tissue now is on the coronal region, and the palatal part of the bone, of the exposed bone, was covered by the mucograft, and stitches made with polytetrafluoroethylene. I think this is a very good suture, and it's stable minimum for 4 weeks. So this is one case. Second case is almost the same, but in this we had a bicortical screw, some explanations thanks to my team. And next step is the other side is almost the same, but we had to fix 2 cortical plates to have a good wall situation, because there were 2 walls missing, the palatal part and the buccal part. And here you can see the apical part of the teeth are almost stick together, and we said to the patient, we need this gap filling bone augmentation, but meanwhile we are waiting the 6 months to have a very good bone in that area. She needs again orthodontic treatment to make sure that the apical part, that the roots of the teeth are going away, are descending a little bit from each other, so there is a chance to put in implants. And clinical findings here: covering of spongy bone, Emdogain, and again the mucograft and the soft tissue covering. I will stop here now because it's almost the same what we've seen on the left side. Okay, this clinical situation, and this picture shows you how what orthodontic treatment can do. We have a very good condition, and the gap here of the coronal part is okay, but no way to put in some implants. And when you have these cases, you have to talk to your orthodontic colleague to make sure that they also have a root different, that the roots are not on the same way, that they're not in the same direction. Clinical situation, radiological findings before and after. In that operation, we also removed the teeth to make sure that there is a possibility to make a distalization of the upper lateral teeth. One case, traumatic loss of frontal teeth, a young lady, 29 years old now, almost 29, I think so. And she wanted to have implantation and to avoid the bridge. She wanted to have a recovery because she had a little bit of gummy smile, and afterwards she wanted to have a single crown implantological approach. Same situation, big loss, but she had bone augmentation beforehand, she had hip graft, she had implantation, and she had failure of all of these things that had been done. As well here, palatal incision, lateral incision, soft tissue movement, and in the middle there is not a very good soft tissue condition. It's a scar, and whenever you have scar, you have to cover it with a membrane, with titanium or with Teflon, for example, the deficit is almost 2 centimeters. As you can see, I will show you the 3D-Bonebuilder before. And this is the Bonebuilder. Normally, there are some recommendations. My recommendation is put in some metronidazole to suck it and to remove all what's inside, all the air what's inside the augmentation and the augmentative, and then you can put it. It's like a Lego stone, and it's fitting very, very well. When you do the planning together with botiss, please tell them that they make a small extension for covering as well the lateral teeth. Here you can see it here on this side normally, yes. It makes it better for you to find the correct position of the Bonebuilder. Sometimes it's moving a little bit, and this extension gives you a very, very good fit. This is scar, as you can see here, and the Bonebuilder is placed and conditioning the recipient side, make it bloody, and the nose is not far away here, so it's only 2 or 3 millimeters. Keeping in mind not to insert the screws too deep, not to have problems with the nose. Yeah, screw fixation, minimum 2 screws. You can put it also in different directions. And this is the human spongy bone, some chips, and a C2+ titanium reinforced membrane. In all of these cases, or in most of these cases, it will end up that you have an exposed membrane to the oral cavity. And for that reason, it is mandatory to have a safe augmentate under the titanium membrane. There are mesh grafts. Our first cases were covered by a mesh, but mesh, when it is super exposed, you can see the bone, and with this PTFE membrane, with the C2+, for example, the C2+ membrane, it's even better because the soft tissue is creeping under the membrane, and fixation, I hope it's not in the teeth. It's like this. And to improve the quality of the soft tissue, we recommend, I come back later to this case, we recommend to have a platelet-rich in growth factors, a PRGF membrane as well, super exposed. I will show you this case later on when we put it on. This is one patient who already had some implantation, and she had 3 big problems. She wanted to have fixed dental restoration, and the frontal teeth were moving. She had bone loss in the lateral part of the lower jaw, and she had a problem on the right side. I only wanted to show you the point 1: implantation, bone augmentation, tooth extraction, and implantation onlaplasty at the second, and the hip graft interpositioning I don't want to show you, so it's only up to the first, to the frontal teeth. When we do so, there's a possibility to have a Ringbone Technik. The Ringbone Technik is using spongy bone in a ring with a big hole inside where you can insert implants immediately. And this is a technique. Normally you have special instruments to make the alveolar ridge bloody, and then you put in the augmentation, the allogenic ring bone. Giesenhagen and Yüksel are doing a lot of courses to this, and then you could put in also this implant. Normally it is useful to cover it via membrane, as you have seen before, and this is a procedure from YouTube. It's very easy. Make sure that it is fitting very well, and you put it in, and you can put in an implant. When you do so, make sure that you have the right implant. We recommend SIC because it's lightly tapered, and the SIC Max, specially made for the maxillary, so for the spongy bone, does fit very well in the spongy bone. And this is the clinical situation. So we made tooth extraction, and you can see there is a wall defect here, but there is still enough bone on the root side on the upper part. This is teeth removement, and the left lateral is also extracted. We used at that time the non-allogen ring bone. We used the hip from the patient and made the ring out of the patient. So it's an autolog Ringbone Technik. And small incision, operation done almost in 2 hours, 2.5 hours. And this is finding the right position. And this is the implant covered by a special individual abutment. And we were able to have a fixation up to 35 Newton centimeters in 3 of these implants. And the left lateral incisor, we were not able to fix the implant immediately. So we have bone augmentation in this region on 3 implants, and immediate loading of the fixed bone, holding the soft tissue. And only on this side, this is a mirror, sorry, so this is a left lateral incisor. Here you can see the X-ray. Only in this case, it was not possible to fix the implant. It was only a bone augmentation. So later on, it was covered by a special membrane, it's a Jason membrane. And later on, we were implanting and doing a ring bone from the mandible, from the mandibular angle. This is a little bit hard bone. This is a D1 bone. I recommend the soft bone of the hip, but we do not know till now how the resorption rate is. Here you can see the implant. Sometimes you can fit it. Here's the second one. And finally, we have made implantation of the left lateral incisor and the lower parts. And here you can see the before and after X-ray. After Regio 2.1 was moving, only soft tissue, and this is the augmentation 6 months later after implantation. Here you can see the soft bone, and the Hounsfield unit is almost 400, so I think it's a bone in very good condition. Here you can see the other implants covering, and also here crestal bone, new node, and this is for the other implants. Then final prosthetic steps. This is a final dental restoration. Thank you very much, Robert Nikolic, for this, for the teeth here. The lip line is okay for the patient. Otherwise, maybe I would have done different things to make sure that there is a very good red and white aesthetic. But for a lower lip line, I think it's okay. And this is the final restoration after having the final dental restoration. Okay, next case. This is full arch maxillary reconstruction. And I would like to compare what we did before and what is possible to do with 3D-Bonebuilder. First, what is possible for a maxillofacial surgeon when you have these cases? Height is, or this is a treatment plan. You can see it's a functional autogenetic case because the maxillary is reclined and the mandible is reduced in height and it's prognatic. So it's a pseudoprogeny and a maxillary atrophy, what you can see. And you only have 2 or 3 millimeters in the lower jaw, and there are different possibilities. And Nistorm talked about reconstruction of the atrophic maxilla with interpositional bone grafting. Sometimes you use this before to have a lot of bone you have to use when you want to make a LIFO1 osteotomy. So interpositional bone grafting and LIFO1 osteotomy, or 2 steps or 1 step, 2 together, and how otherwise implantology is not possible. And we met this case, and we decided to have an interpositional osteoplasty of the rib in the mandible, because the harvesting of the rib is okay, and it's not so painful. Normally people say always. So my patient say, use my rib, and this is the splitted maxilla opened from an extraoral approach, and this is the clinical situation after. There is a X plate to fix it, and you have a D1 bone normally in the mandible, and you have to fill up this gap, and then you have a very good B cortical bone in the mandible. We made an LIFO1 osteotomy and a hip graft osteoplasty of the maxilla, and ended up with a functional class 3. So this is not the end. So we had to do a second step, second surgery step. We made a segment osteotomy to put this chin backwards, and we made a second onlay osteoplasty with the second hip to superexpose all this bone to the maxilla. And we ended up with almost a chance to insert implants. This is clinical situation after anterior segment osteotomy using an extraoral approach. Here you can see the cuts of the extraoral mandible cut. And we decided, because she was a heavy smoker, we decided to make implantation as well, to insert the implant. It looks a little bit strange when you do implantation like this, but it is possible to have a very good soft tissue, because soft tissue in the resorbed mandible and maxilla is sometimes a very big problem. You can read this from Grisha and Wang about smoking and the clinical oral implants research. And this was, how do you say, a social indication, minimum 2 implants, and it was covered by a cover denture with locators. In the lower jaw, we made a special kind of bar construction. This was made by Fleming Dental in Germany, and they are in Germany and in Norway, and maybe in different other countries. Locator height 4 millimeters, gingival height, and that was the final recovery. But this is very big surgery, and when you do big surgery to a patient, normally people don't like it, that you do things like this. They have scars inside, they have pain and so on. Afterwards, maybe they have some problems with the TMJ or whatever, because you cannot find the right height. So the second way is to have a full arch maxillary reconstruction using a bone builder. Till now, the melting process is only possible for small parts of a bone builder. And this is one patient we treated in about 1 year ago in August last year. And he had the same situation in the maxilla, left only 1 or 2 millimeters to the maxillary sinus. And the planning we did were like this. Morbus Bechterew as well, spondyloarthrosis deformans. And this was our planning, to put in 4 pieces, to stick it together, and have a maxillary reconstruction to rebuild the complete maxilla, the alveolus. And that was done in Germany not that often, so we decided I have to reduce a little the noise.
Ich glaube, inzwischen ist so wenig Knochensubstanz übrig, dass
Botiss
eben nur sehr schwer halten.
is sending you, if you want, a 3D model, so you can do the explanation to the patients as well.
Wir haben auf der Basis dieses Modells, das kann man hier sehen.
This is also a tool for good information, and you put it into the papers of the patient, say, look, you have different possibilities. You can do it the conventional way. I use your hip, or I use different things. But this patient at that time was 77 years old, and he was playing the trumpet as well, and he wanted to have fixed denture without having big surgery. So we made this operation in a course here in Germany, and 4 pieces were melted. I'll do some explanation, yes.
Von einem Spender. Und der wird aufgebracht und bietet jetzt eine Leitstruktur.
And I'm just explaining some morphological changes in rebuilding the bone, and just telling after 6 months there is almost native rebuilt bone.
Das verlängert die OP-Zeit erheblich, denn der Knochen muss erst passend gemacht werden.
Yeah.
Das neue Verfahren hat bestimmte
The new procedure now is
weil wir erstmalig in der Lage sind, natürlichen Knochen
reducing the time of the operation, not to harvest the only different bones from tibial parts or from the calvary parts. Calvary sometimes I like very much, but it's very hard. People don't like it. The man, their scar on the skull. This is again the spongy bone, and it's not only fixation of the bone, because you have to fill up all the gaps, and you use blood, and then you
2,5 Stunden dauert das alles. Rund 10.000 Euro
almost 2 hours by operation. You can see the intraoral part
nach dem Aufwachen erwartet,
and fixation. People just the patient starts explaining what will happen next, and this is a clinical situation you have. And when you would like to do this operation again, there are some problems you will figure out. There are some problems. The first is when there is less bone, you don't have any possibility to fix the screws. So you have to make it a little bit like a fence, a Jäger fence, a hunter's fence, we say, and then you can fix it. This is DVT, some slices in the DVT you can see, especially in the lateral parts where the 1/6 or the molar region is. You cannot fix it directly, so you have to go with very long screws to fix it, and the best is sometimes it's fitting very well. But the second is how to cover all this augmentation, and it was one of the cases we made in August last year, and I had no membrane covered. The augmentation were not covered by non-resorbable membranes, and after a while, and the patient was not wearing the prosthesis for a minimum of 3 months, we find out that there is some dehiscensis, and we had to remove this part of the bone. It was typically there was an inflammation, and we had to remove one of these screws. This is normal when you make so big augmentations. So not only where to fix the screws, it's how to cover the bone. And last but not least, we recommend the PRGF treatment. We take the venous blood normally, and there are 2 fractions what you can get. There is one fraction, it's called fibrin, and the second is the growth factors. When you make membranes made of the after the method of PRGF, maybe most of you are familiar with the system, you can cover it, and the wound healing is improving. And in this special case, we only used the fibrin membrane to cover all the bones, but it's stable for 3 or 4 weeks. After this, there is no it's not safe because it's resorbing, and then you cannot use it. This is the case I showed you before. This was the recovery of the young lady. Now we are doing it like this, as I showed before, the cytoplast membrane, the PTFE membrane, and over putting on this, on top of the PTFE membrane, we are making the PRGF membrane, so improving the quality of the soft bone, but covering also the bone with a permanent membrane. So, and later on, after 6 months, we have the third problem. Every one of these cases had to be planned. And the planning tool is based on the bone. Sometimes the bone is not mineralized, so you cannot find out the right dimensions of the crestal height for implantation. And this is a very big problem because you cannot make a differentiation in soft tissue, hard tissue. So where to put the implants? So sometimes it's a hint, but it is not that safe. Or you have to wait longer. But when you wait longer, on the other hand, you cannot, you're not sure if there's still bone or what's about the resorption. So these are the three big problems we had in this special case. Maybe you can avoid it. Sometimes the screws are not fixed in the natural bone. And finally, we ended up with SIC max implants with shorty implants, because especially in the lateral parts of the maxilla, we had a loss, and in the central part as well, but this normally is not charged because of very bad aesthetic results. So we were able to insert the implants, and the clinical finding were much better compared to what the radiological diagnosis was after the augmentation. So maybe we have to figure out, is it better to wait a little bit longer or to make a definite PTFE membrane or a mesh so that we can measure again the height of the crestal bone. The summary, I will come to an end, so it's almost 50 minutes. I've shown you the beginning, our beginning of allogene block and implementation in this first case, the Gordon-Gall syndrome and the histological findings. I showed you how to improve the soft tissue in the second case using the Osmode expander, hydrogel expander. We have seen the possibility of monocortical or bicortical max-graft cortical shields and filling up the gaps. We have seen a classical 3D bone builder, one dimension in the anterior part of the maxilla. The second was the possibilities of Ringbone Technik, and this case was not made with the allogene block, but was made with the autolog block. You have seen the comparison of the conventional way we treat people who are very old or suffer from autogenetic problems or highly atrophic maxilla and mandibular. I have also some slices for nerve lateralization, but I'm not selling this. And last but not least, we ended up with a full arch maxillary reconstruction using 3D-Bonebuilder. Summary is a subject to recent literature. When we see clinical outcome of augmentation, there is normally no clinical evidence according to the method, and we've seen in our investigation that the same Chapasco had also published in 2009. There's also no difference between membrane technique and allogene or autolog bone augmentation as described by Meyindat, and no difference between the material of membrane. But I highly recommend putting in membranes nowadays, putting in membranes that are non-resorbable, because normally you have to come back to the case, you have a reopening, and then you can see that there is a very good covered bone. But in distraction osteogenesis, normally the bone and the gap is a little bit better. When we see parameters like biocompatibility or osteoconductivity and the dimensional stability, there's till 2013 no criteria that shows any differences between different methods. We had, the conclusion is the bigger the defect, the bigger the resorption, and less osteoconductivity from better TCP than bovine or autolog material. And peri-implantitis was described by our Fazli and the implant survival rate is not a matter of the technique, it's almost a matter of the doctor who is doing the surgery. And for the more detailed information, you can see the next slides, 96 to 106. And I will come back now to the chat room. So one question was, platelet-rich growth factor is PRGF plasma-rich in growth factor? Yes. One question from Alan Gagnon was the pink aesthetic result of the 4-implant case with bone ring technique does not look stable with not a 3D graft first, then mucogingival reconstruction. Yes, you're right. Normally you have to make the decision. When you make a 3-dimensional reconstruction, beforehand you will lose all of the epithelium that is normally fixed to the teeth. So we decided to have a normal gingival rim. So that was our indication for immediate implantation. And the patient asked for having as fast as possible the implants because she's a VIP here and she is handling with a lot of people. Faraz Patel is asking, in your experience, is cortical or cortical-cancellous bone grafts more stable over a long time period? Yes, there are some investigation made from a German group, from the German maxillofacial surgery group. Normally, the cortical bone, when it is very thin and it's like a wall, and not a monocort, not a very big one, only the thin one that are reconstructing the wall, filled up with a gap of spongy bones. This gives very good long-term results. Okay. Endochondral, long bones. Is a 3D allogenic graft from jawbone or long bones? No, it's David Oyster is asking if it's 3D allogenic graft from jawbone or is it from long bones? Normally it's made from tibia, but you have to, maybe I have to give back this question to the botiss team, and you can ask directly the team from botiss. So, Mr. Patel, in your experience, okay. With regards to PRF, also, sir, how's your experience been so far? So, using PRGF, I normally recommend putting in only the first fraction, because the first fibrin fraction gives you wound healing that is very, very fast, and it's very stable. So you can fix it. It's not fixable by a membrane pin, but you can fix it, and it's quite good for the soft tissue recovery. There is a second fraction with growth factors. My experience with the growth factor is not that good, because sometimes you also put in some inflammatory mediators and you have a big inflammatory infection. I say infection, but it's an inflammation. And when you have inflammation, the bone loss is going higher. So in this case, we only put in the first fibrin membrane. Yeah, this is a very tricky question. Kobe Landsberg, thank you for this question. In case 4, you mentioned that there is a way to treat the scar tissue. Can you elaborate on that? Yeah, so this is very hard. When you have the scar's very bad in the soft tissue, so rotation flaps from the other side, augmentation using osmet expanders. This is almost the best thing. Or you make a cicatrization, you put out the scar, you remove the scar, and then you have to make sure that there is you make a splitting of the periostal flap, and you remove the natural soft tissue together. Then it's a little bit on tension, but the scar is reduced. Then you wait, and then you make a very small osmet expander. So the growing of the soft tissue is going and going. Then you have mucosa, but when you have implantation, you normally use gingiva. So later on, you have to make a gingivoplasty to fit very good to the implant region. Oh, thank you much. Thank you very much. Yes, okay. So one question from Andrew Sarafinchan is, what is the treatment for exposure of the bone block? The first is remove the surface till it is bloody. Put on chlorhexidine, digluconate, the soft tissue, and make antibiotics. My experience in recovering is not that much. It's not that good. So don't make new stitches because it's going infected. When there is super exposed bone, remove it. Let the soft tissue grow on the bone, and when you make a new approach for implantation, you can see is there enough bone or is there not enough bone, and then you have to decide, make a second augmentation. So do not compromise the bone, be gentle to the bone, remove it, otherwise you have an actinomyces infection and you will lose a big block. So there are 2 blocks I had to remove because it was exposed and they were infected. And it's very bad for the nose, even for the patient. So the faster you remove it, the better it is for the patient. And say, look, the soft tissue is not that good. Maybe it's a possibility for distraction osteogenesis, or make a sinus lifting when it is a posterior part. So there are different other ways you have to explain to the patients. Never lie, tell the truth. Mr. or Mrs. Santos is asking, what is your opinion on use of particulate grafts along with block grafts, either autolog or allografts, to control bone resorption? Yeah, this is a very good idea. I normally use it when I make sinus lifting because the autolog bone is not mineralized and you do not have any ideas where is the resorption. You can do this when you make a 3D cone beam technology. Then you can look into the bone and you can measure the Hounsfield units. We normally do this after 6 months, but there is a rule coming from the Freiburg University is one third, 2/3. So 2/3 autolog bone and 1/3 beta-T calcium phosphate, for example. And the mixture is very good. So I recommend this way, and I do this. I also do this mixing of different materials for having better radiological proof.
Thank you very much, Dr. Nilius, for sharing your lecture and your insightful information with us. We'd also like to thank botiss for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You'll receive an email notification with the link to the recording. Further questions for Dr. Nilius may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Nilius will be sure to get back to you as soon as possible. Please be sure to visit the botiss educational platform, www.botissacademy.com, and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.